My name's Mark Quigg. I'm supposed to give you your annual sleep deprivation is bad talk. I'm from the Department of Neurology. It's 7 in the morning. I normally don't give talks this early. Please feel free to fall asleep if you need to. Maybe that's the main benefit of this talk. An actual case. I saw a nursing student who showed up in clinic after referral from the emergency room, who had an episode which she really didn't remember much about, but it involved loss of consciousness in a car wreck. And she was driving home after a day shift on 29 South, and she says the next thing she knows, she's upside down in her car on the highway. And the key bit of information was it was a different road. All right, she started off on 29 and ended up on 64. And she was alert, thinking normally in the emergency room. Her various labs and tox screens were normal. And she was started on Keppra for having had a seizure. And she really hated the Keppra. She thought it was causing her irritability and more sleepiness. So this is basically her journey. So she started here at end of her shift. She drove down the usual path, going down 29 South. That was her destination, but she ended up there. So somehow she ended up from point A to point B and knows nothing more than almost the first start of her trip. She's had trouble staying awake in classes, but she had no epileptic injuries. That's what we call head trauma, brain infection, or febrile convulsions. Something called the Epworth Sleepiness Scale, which is basically a sleepometer, said that indeed she had hypersomnia during the day. She slept about 6.5 hours a day, going to bed at midnight, getting up at 6:30 for work. Prominent catch-up sleep during the weekends, so she said she could sleep till noon if her bladder was bigger. She often went to bed late because it was hard for her to fall asleep very quickly at the night. And that was the significant parts of her history. She was asleep when I walked into the examination room. She had no risk factors for obstructive sleep apnea, which is the sleep doctor's always kind of first checkoff. So this was a young woman with chronic non-progressive hypersomnia and sleep onset insomnia who had this spell with preserved ability to drive. And so I constructed a differential diagnosis of hypersomnia. I doubt she had an epileptic seizure. Drugs, concussion, retrograde amnesia, or malingering. That was kind of the initial differential diagnosis. And I checked an EEG for seizure and it was normal. And we did a sleep study. And she had a very short sleep latency, meaning that when they turned off the lights, basically she was asleep the second they turned off the lights. Normally, these sleep studies are quite rote, and they start waking people up and rustling about to, turn over. But I instructed the staff to let this person sleep in as much as possible, and so she slept for 11 hours straight. We did a sleep latency test to see if there was a primary hypersomnia or narcolepsy, and she fell asleep in 10 minutes after sleeping for that 11 hours. And she had no sleep onset REMs, which were the sign of narcolepsy. So her diagnosis was what? Basically chronic sleep deprivation. And think about it the next time you're on the highway and you see this car starting to slowly drift out of its lane. That person is asleep. And that's what this person did. They just kind of carried on in kind of an automatic driving. Anyone here probably has realized that, hey, it's 10 miles down the road. How did I get here? And that phenomenon is what this person did. She just happened to fall a little bit too asleep doing it. So the case illustrates that sleep's important, that sleep deprivation and insomnia are worth evaluating and treating. Just about everyone thinks that their sleep is normal because it's something that you do every day and it's hard really to compare to everybody, even if it clearly isn't so. So the only way to figure things out is ask. So the reason that I was able to take her off anticonvulsants because I thought to ask her about her sleep habits. Sleep deprivation is accumulative, meaning that a little bit of sleep deprivation every day is just as bad as staying up overnight. And addressing sleep problems can improve personal and public safety. So a little bit of history. Why I am here today is because of the history of sleep deprivation in medical education. So let's see how we got here. We got here because of Hopkins. And so William Osler, basically the father of American medical education, designed his training system at Hopkins based upon what he saw from German models of an apprentice-style training system. And essentially what that involved for the interns and residents was an every other day call system, which essentially was 36 on, 12 off, forever. And every once in a while you could get Sundays off if you could bargain with your buddy for he could cover you. And if anyone's been up to Boston and seen the old MGH barracks, if you will, those were designed specifically so people could just live there. And indeed, you were an intern because you were interned into the system. Famous surgeon William Halsted, he was trained by Osler. He was famous for his surgical skills, taught many people to be excellent surgeons. Had an example, an extremely robust work ethic. He was there for hours in the hospital. It turned out he was also addicted to cocaine by his early 30s. So you can't burn the candle at both ends. In 1984, there was a tragic death in a New York hospital, a young woman named Libby Zion, who happened to have some rich, influential parents. And this inpatient death, through a series of lawyerly maneuvers, was tied to the proximate cause of sleep deprivation of a resident. Within about 3 years, the impetus and public outcry for sleep deprivation and public safety resulted in the New York legislature unilaterally saying there's going to be an 80-hour work week and that's it. From there, it took another 5 years or so before the ACGME itself said, okay, this should be countrywide and uniform. And the first work hour standards were approved. And in 2011, and then most recently in 2017, they've been tweaking these standards in order to meet some of the unintended consequences of duty hour restrictions, which were updated to the nicer term, learning and working environment. Okay. So what was the public outcry and what was the need? What's the justification for work hour restrictions? Well, if you measure this Epworth Sleepiness Scale, again, a clinical measure of just how sleepy people are, you can see that, well, sleep apneics score with sleepiness. Narcoleptics have the worst daytime sleepiness, and medical residents score right in between. So now I can testify when I was in y'all's shoes, I could fall asleep anywhere and any time, was quite proud of it. Resourcefulness and falling asleep was and finding free food. Those are the two things I was really good at. These guys, Williamson and Fayer, made a landmark article when they were very clever in designing a study to compare the effect on cognitive testing of various degrees of sleep deprivation compared to alcohol use. So their control was not just normal, but into people who would consume various levels of alcohol to like blood alcohol level of 0.1. And then they would compare, and then the point of these studies was to demonstrate that sleep deprivation basically was equivalent or not distinguishable from having a blood alcohol content that would be considered drunk driving. So these guys kind of really slammed home the point. And this study design, there's many, many papers with similar ilk following this particular study. There's only been one randomized controlled trial of sleep deprivation effects on patient care. Only one. And this was designed up in the Harvard system. And they measured ambulatory polysomnography on interns rotating through ICUs on the old schedule and the new schedule, the gentler, kinder schedule. And they had outcome measures of attention deficits and hours sleep and woke by the interns. And they found that the traditional schedule had twice as many attentional deficits at night and 1.5 times of those attentional deficits during the day than the new schedule. The second thing they measured during this study was they had kind of little auditors following around the interns in the ICU. And they had a kind of a graded score sheet as to what would be a, quote, serious medical mistake or medical error. And basically the traditional schedule had twice as many, quote, medical errors as the new schedule. So based upon that one study, they said, oh, okay, this proves the point. The other justification is kind of similar to the case I opened up with, the nurse driving sleepy on the road, is that sleepy people in the medical system experience more injury, more risks than non-sleepy people, or at least there's associations because there are no controlled studies with this. So needle sticks, driving home post-call seems to be a theme here. Can be dangerous. I like the last study. This was a Hopkins study in which 70 pediatric residents, 50% of them fall asleep at the wheel post-call versus only 15% of faculty. Shows you how the distribution of sleep deprivation was in those times. Let's see, I'm going to skip that one, keep up with time here. This was a better study that driving post-call has a higher crash risk than other times. And this was a prospective study, a nationwide survey of nearly 3,000 interns. And the odds ratio for reporting a motor vehicle accident or a near miss was higher after extended work shift. Okay. So, yeah, so it's basically very, very much higher after working for a long time. Driving safety is also tied to time of day. So those folks in neurology, we have the system of acute stroke call, and lots of people have to sometimes come in from the hospital, and that driving window in the dead of night, in the graveyard times, is much more dangerous than driving at other times, not only with medical training, but with people in general. The worst times there's nothing good happening on the road between midnight and 6. Okay, so from all those justifications, the ACGME came out with a series of work hour restrictions. And I'm not going to go over all the details because you guys have been imbued with all those and live in the system. The core features, though, is that supposedly we're supposed to have an 80-hour per week maximum duty hour with a 24-hour maximum shift and some 4-hour slop room for transfer of care. You're supposed to have a day off per week and in-house call Q3 days. And then a minimum rest period between after in-house call and next shift. And I kind of look at these and I kind of compare what I did. The worst year for neurology was the Resiturn year, or PGY2 year, and we had 5 months every other night call. So this looks pretty welcoming. That was nice. Okay. The important question from these duty hour restrictions is that I think we have to do due diligence and ask, have these changes in work hours in medical training led to intended improvements? Okay. What has been the effect on patient outcome? What has been the effect on y'all's lives? Okay. And the jury's still out on this. The problem is that based upon actually, I showed you a bunch of justifications for work hour restrictions. There's only been one study, as I mentioned, that was randomized that compared actual medical outcomes, and that was a theoretical basis. And there's been actually a whole bunch of editorial battling whether or not the design of that study was actually done correctly. The problem is that work hour restrictions, although we can all acknowledge that the intentions are good, and certainly I wouldn't want to wish 5 months every other night call on any of you. It's actually no fun. But there are unintended consequences to this that grumpy old people like me still think of occasionally. Those every other night calls, I was an independent machine. I just did my thing. I had no one bossing me. It was wonderful. We didn't have computers, and I don't think that any of these systems took into account the acidic effect that I think EPIC has upon medical practice. Labor costs, one of the really undiscussed things, but as a true consequence is that if it takes 7 residents instead of 5 to fill the needs of an inpatient program, do you pay $100,000 in direct and indirect costs for a new education position, or do you spend the same amount of money for a nurse practitioner who can bill directly? So these are the consequences in an educational system that we have to think of. So one of the unintended consequences is, well, if you guys have more time off from work, what do you do with it? And this was a hint that, this was a study that took the number of hours worked versus the number of hours of slept due to a measured from a survey of residents of all subspecialties. And they basically showed a very weak correlation between hours worked and hours slept. So it can send you home, but it doesn't mean you're sleeping. Okay? There are no demands that you guys sleep. This is the results of one of the biggest meta-analyses that have been done, where it took all a huge number of studies. There were 27 as in 2015 that qualified for this meta-analysis, in which they tried to measure the outcomes of AC/GME duty hours. And this was all services, medical, surgical, anesthesiology, et cetera. And they analyzed the effect of ways to try to shoehorn these work hour restrictions into patient care needs. And there was various programs have tried night float, very short shifts, demanded protected sleep time, What they found across this meta-analysis is that there were no real significant effects in patient outcomes, morbidity or mortality. That there are no significant effects whatsoever on resident quality of life or, quote, wellness. And they found that there was actually a significant impairment, according to self-survey, of the residents on resident education. And the worst effects, they thought, were continuous night flow, which is what some programs have done to try to meet these needs. There's been only one randomized controlled study to try to measure the effect subsequent or after duty hour restrictions to find out, okay, so what's the status? What have we done to improve these things? They randomized residents to every fourth night call with a 30-hour shift or a shift-based 12-hour maximum system. So more shifts, but shorter. They measured sleep time. There's no difference. The duration awake was shorter in the test group. And the NICE rotation, the test rotation, the residents liked it less, citing work hour compression. In other words, there was 10 pounds of work to do, but you had to shove that 10 pounds of work back into a smaller slot. So these are real world issues with trying to comply with work hour restrictions in the real world. It's clear that more tuning needs to happen. There's cheating on duty hours, right? You've got 10 pounds of work, you got to do that 10 pounds of work. There's compression of tests. Again, one of my bugaboos, I really hate Epic. I don't know, y'all have had nothing different from the electronic medical record. I think it's been terrible on medical practice and on medical education. It's spending all time on this computer. I never did that in training. Much, much different. And these systems were not designed with this in mind. Even though these things may not be directly linked, also there's a growing concern about burnout, not only in the education section, but in guys like me. And really doesn't comment. This was a very famous study it came out last year, but it's made big rounds in the medical education resident director world, is again trying to fit all these competing needs into an education system. And this study basically said our system is making things worse than better. They did not comment directly on duty hours, but I certainly wonder about these things in context. So let's step back from that and say, well, why do we sleep in the first place? Sleep has a series of non-exclusive functions. Restorative, in other words, biological homeostasis. Sleep is required to keep all the systems running in a smooth fashion. There's an adaptive, and there's cognition and learning. The homeostasis effect is imbued within our auto-regulatory systems. So for example, sleep is necessary basically to keep your metabolism systems working normally. People who are sleep deprived have higher levels of cortisol, for example. And that hypercortisolism has consequences in weight gain, in prediabetes, in child obesity, etc. Adaptive. There's all kinds of I'm a chronobiologist in my early research days, and there's all kinds of fascinating experiments on people proving that the circadian timing of things matters. And this was a famous study that showed that if you're a baseball team in the major leagues, that if you were playing in the wrong time zone, you would have at least a one-run disadvantage in a game. So this was one of the studies that shifted around Major League Baseball games to keep people from flying across the coast all in one day and then playing the next. I'm not going to go into the huge literature of the need of REM sleep and its central role in changing short-term memory and long-term potentiation to longer-lasting cortical memory systems. But the point is that you need your REM sleep to lay down new memories. Something to keep in mind, even though that we're going to be talking about the importance of naps and maintaining normal sleep as much as you can, that we're limited as biological animals to what sleep in the inappropriate time can do. And that's because basically we can model the daily propensity from sleep from two competing systems. One is process C, that's the circadian cycle. There's a machinery including orexin and the suprachiasmatic nuclei and all these brainstem mechanisms that are basically from the nadir at the dead of night, around 4 a.m., increasing through the day, this whole neurological system that is working harder and harder and harder to keep you awake. And then in the dead of night, right around normal bedtimes, that system crashes. And then that allows you to sleep. And the opposite of that is process C, basically sleep debt, or you can think of it as a sleep battery, in which your ability to maintain vigilance is restored during the night, during sleep, maximizes upon when you wake up, and then you draw down on that battery as the day goes on. And there's a inflection point where these two processes kind of meet at a nadir in the early afternoon, and that's why they invented the siesta or coffee hour. Okay? We all have this kind of biphasic propensity to want to fall asleep naturally twice a day. One of the consequences of having these systems is that there is no feedback system to the process C, to the circadian process from sleep. Sleep doesn't restore the circadian pressure to stay awake. Okay? All it does is restore the sleep battery. They're independent systems. So what this means is that, for example, if you have a very long night, like if you're cramming for an examination, and then you have your exam, and then you try to fall asleep, the point is that if this exam is in the morning after a whole night late up, that bump that you get from the sleep debt doesn't come, okay? So your brain's kind of expecting this bump of vigilance and attention in the morning, and it's not there because the only thing there is that circadian system pushing. And then when you try to sleep later in the day, the restoration, the depth of sleep that you can achieve in the midday is now limited because the circadian system is pushing harder and harder and harder, and you can't fall in the deep dead sleep. You're limited to a light sleep. So that's one of the reasons why I stopped cramming for examinations, for example. It just doesn't work. Okay. So let's talk about mitigation for sleep deprivation. And it looks like I'm going to probably end up a little bit early, which is great. So what are the symptoms of chronic sleep deprivation? Fatigue, lability of mood, memory impairment, poor attention to task, and very short sleep latency. Sounds very commonsensical. Now, one of the things that naps do, a little nap, a little nap actually, even though I told you that you can't sleep deeply during the day and catch up sleep, a little nap actually can be quite restorative and will often return the poor vigilance that can be measured to something within the normal range. Okay, a little nap is often more effective by comparative studies than a cup of coffee. For example, in medical care, they have tried to attempt to measure the effect of, say, okay, it's nap time to a bunch of adults working in the emergency room. But the point is that that kind of scheduled nap for people working a 24-hour shift really did them a good job. It really worked for them. Now, finding a time for that little nap may be difficult, but that's one of the things that I opened up this with. When I was in training, I could sleep anywhere at any time. And free food and a nap is something that perhaps always can be looked for. Let's see here. Sleep hygiene. One of the implications of that model I showed you, the interaction of the circadian timing system and the sleep system, is that regularity of the sleep-wake routine engenders the best and deepest sleep. So whatever you can do, maintaining a regular schedule is going to be great. Develop a pre-sleep routine. I opened this talk with the story of the nurse who could never fall asleep. She had insomnia, even though she was actually quite sleepy. And it's because that's when she really started to wake up. Okay? Some people have, especially young people, I'm going to qualify all y'all as young, we have a circadian shift. So most of y'all really get energized around 9 o'clock, 10 o'clock at night. That's the tendency. Whereas guys like me, we shut down then. We go to Denny's for the early bird special, right? So there is this age-related tendency to be more energized during the evening. But the point is that's the time not to start having the coffee and the beer and the alcohol, because it will mess up your subsequent sleep. When you do have days off, protect that sleep time. Enlist your family. Use that time off to sleep. I showed you that graph, that time off and actual sleep bears little relationship. Well, try to make it your relationship. And lastly, if you are going to work your 24-hour shift, the biggest advice I have to you is do not be sleep deprived the night before. That's the day when you really should store up as much as you can prior to a 24-hour shift. Do not go in there with a sleep deficit. Basic sleep hygiene. These sounds commonsensical, but you'd be surprised in my sleep clinic when I talk to the patients with insomnia. Common sense measures such as trying to keep a cool temperature in the bedroom. Keep it dark. Keep it quiet. Don't bring the iPhone to bed. These are common sense measures. Let's see here. Some of these are repetitive. So, yeah. I'm skipping some things because it looks like I need to do some editing. It's the same thing here. One of the issues that I have to mention a lot to my patients, even though I'm going to say caffeine is a good thing sometimes when you're at work to maintain attention, Caffeine too late engenders sleep onset insomnia, and you'd be surprised how many people for dinner will wolf down coffee or Mountain Dew, which seems to be a favorite down in Southwest Virginia, or whatever, right before bed. And again, it sounds like common sense, but unless it's specifically said, some people just take that as normal habits. I saw a kid referred to me for ADHD. That was does this kid have ADHD because he's doing terrible in school? Well, his truck driver dad thought it was perfectly appropriate for the whole family to have Mountain Dew at 8 at night before trying to go to bed. Little 8-year-old kid wired on caffeine. Made sense to the truck driver because that's what he does. So, alcohol. Alcohol is one of the weird things that a nightcap, as you call it, is a great way to add a sedative to try to go to sleep for some people. The problem is that as the alcohol burns off, there's a parasympathetic and sympathetic shift in that your core body temperature actually undergoes a switch, and it often wakes people up, this shift in body temperature. That awakening typically occurs at the dead of night, and it's often quite hard to fall asleep again. So alcohol at night is a double-edged sword. Exercise. Getting exercise routine, fitting that in, is about the most important thing in this list that you can do for yourselves to promote a subsequent better night's sleep. Everyone has different schedules for their daily exercise. I'm a morning person. There are other people who do it at night. Doesn't matter. Regularity in that is very, very helpful to kind of burn off the day's angst before you try to go to bed. So, summary. The common program requirements are here to stay, and the intention, I think we have to recognize that they're all, even though I had a lot to say about their unintended consequences, the intentions are good, and I think that many of you could not imagine going back to the old system, and neither could I. It's one of those things retrospectively, oh, it wasn't that bad. No, it was terrible. 5 months every other night call is no fun. Ongoing evaluations are required to tune benefits and consequences of work hours. So these things will be tuned by the time you guys are gone and the next generation comes up. This is an active progress in adjusting. Sleep deprivation is a common problem. It does have physiologic consequences, mainly in driving, and mitigate sleepiness by strategic use of caffeine and naps. And if your friend is looking like he has a blood alcohol content of 0.1, which is the physiologic equivalent to a night's sleep deprivation, tell them, yeah, go to sleep. And that's it, okay? All right, so we are 20 minutes early. That means you have 20 minutes to catch your nap. But there is coffee outside, and I'll take any questions, but otherwise you guys are free.